So this is an algorithm put together, ASCO Daily News, Maria Burlon, fantastic work, Mexico, work with Tony and put kind of this setup. And what should come up from this schema is it matters when you recur, it matters how you recur, and also matters the options we have available. So I'll try to address a little bit of that. So the first thing is when we have recurrence, meaning when cancer comes back, I think it's common sense for us to think, well, Pedro, it's different if cancer is coming back with one spot or is coming back with disseminated metastatic disease, right? It makes sense. It also, you would say, well, it also makes sense if patient, if you have recurrent disease 6 months after you've completed a year of pembrolizumab, or if disease comes back with multiple spots 5 years later, right? Intuitively, we would say those are probably different patient scenarios and there's probably different biology. So the first thing we try to answer the question is, if I see a recurrence, do I need to treat? That's one question. And the other one is, okay, if I do treat, can I consider local therapy? And this slide is, we actually can apply this for post-adjuvant or metastatic RCC for patients who did not receive prior nephrectomy. So you always got to think about those things. So what does that mean? So going back to the keynote 564, you can appreciate that, and keep in mind, people who end up getting something, who got recurrent disease, you had about 226 patients on the placebo, right? So of that group, less than half end up getting systemic therapy. What's interesting to me is you see about a quarter, or close to a quarter of patients getting local therapy with systemic therapy there, about 24% or so, just focus on the placebo group, if you will. And then you can see of those who recur, about half, 109 patients out of the 226 end up getting a checkpoint. So there's something about this that tells you that we are addressing the patients who progress after radical nephrectomy, and we address them differently, right? If you want to change your mind, go back to the pembro arm, people who received adjuvant immunotherapy, and you can see that less than half end up getting systemic therapy. So of all who recur, you see that 171 patients who recur, about 73 patients receive something systemically, whereas 37, 20%, 1 out of 5 receive local therapy. So I'm trying to make the point is, it goes beyond the question, oh, what do you do for a patient who receives pembro? And so keeping those things in mind is relevant. And the challenge will be, how do we develop data for us to support? We certainly should do A, B, or C.